Good morning. Welcome to Medicine Grand Rounds. I would like to introduce Dr. Michael Trey, who will be introducing our speaker for today.
Okay. Thanks, Anisha. Good morning, everyone. I am really excited to introduce Dr. Christine Vatovec. Dr. Vatovec is an environmental health and social science researcher. She studies the interconnections between human health and planetary health. She has a background in natural and social sciences, having completed her BS in natural resources at Cornell University, her MS in conservation biology at the University of Minnesota, and PhD in environment and resources at the University of Wisconsin. At UVM, Dr. Vatovec is a research assistant professor here at the Larner College of Medicine, a fellow at the Gunn Institute for Environment, and lecturer in both the College of Nursing and Health Sciences and Rubenstein School of Environment and Natural Resources. She also serves as the Planetary Health Lead for the University of Vermont Osher Center for Integrative Health. Dr. Vatovec's scholarship focuses on identifying opportunities to align healthcare with planetary health through interventions that improve outcomes for patients, providers, and the natural environment. Her first book, Dying Green, A Journey Through End-of-Life Medicine in Search of Sustainable Healthcare, was published last year and has earned her high praise from the likes of Bill McKibben, who is a longtime climate advocate and trusted voice in planetary health. She teaches several courses at UVM, including Climate Change and Health, Planetary Health, and Science and Evidence of Integrative Health. And she was awarded UVM's Part-Time Teacher of the Year in 2020. Dr. Vatovec's expertise and work, I think, are urgently needed in our rapidly changing world and are a testament to the fact that we, as healthcare providers, educators, and researchers, have a responsibility and a very important role to play in addressing climate change and planetary health more broadly. I sincerely hope that this talk is just the beginning of a much larger and broader conversation, and I cannot think of a better starting point than Dr. Vatovec's cross-cutting and innovative work. I hope that you find her work as interesting and exciting as I do. Thank you.
Thank you so much, Dr. Latreille. I really appreciate those kind words. That's really lovely. And I want to thank you for starting the Sustainability Committee here in the Department of Medicine and all the leadership you've shown in bringing people together around this topic and just making that pitch that if you have not heard of the Sustainability Committee, to make sure that you contact Mike and see how this might be applicable to the work that you're doing as well. And I think I can put this one down. Let me make sure. Nope. There you go. Thank you. All right. Can folks hear me? Now I'm moving to make sure people can see me in the audience out there as well. All right. Well, good morning, everyone. Thanks so much. It's really a pleasure to be here with you. And there are many different avenues that we could take in talking about the interconnections between human health and the planet. And these are just three ways we're going to talk about specifically today: clinical care, patient provider education, and policy. Two more that I want to just throw out there in case you are in these realms are research and teaching. So we're going to be talking about mostly the three you're seeing here, but at the Osher Center, we have 5 different working teams, and they include these 3 plus research and teaching. So if something sparks your interest, please let me know, and I'd be happy to work with you in some capacity. No conflict. I want to start with just defining planetary health, and I'd love a show of hands. How many of you have heard the term planetary health? Okay, so people are hearing it. How many of you have seen a presentation on planetary health? A little bit fewer. And of those of you who have seen it, how many of you feel confident that you know how you would actually define the term? Okay, great. I'm glad Dr. Latreille is raising his hand. So that's wonderful. It's a little bit tricky to define because there's lots of different definitions being bounced around. It has, it's a lot of similarity with sustainability. Sustainability also has many different ways to define it, and maybe not any that are 100% agreed upon by anyone. Planetary health is in that realm where each person has their own specific way of defining how this works. But what I want to make sure that you leave with how do you define planetary health? This is the definition that I turn to and that the majority of my colleagues will at least point to. It's from the Planetary Health Alliance, which is an organization that started at Harvard in, I think it was around 2015. They just moved as of November to Johns Hopkins. And they're really thinking of planetary health as a social movement and transdisciplinary field. And as you see here, it's really focused on solutions, identifying those solutions. There is an entire arm of the Alliance that is dedicated to clinical care, clinicians for planetary health. If you're interested, this would be a place to go and look for what are people doing in this area if you would like to get involved. And it's really thinking about humans within this broader life on Earth. So we're just one of many species. How do we recognize that when we are going about our business, the behaviors that we are doing, the actions that we're choosing? This concept of planetary health is not new. It's very much based in traditional wisdom, and you will see that if you start going down the rabbit holes of the literature on planetary health, you'll see that it's very much pointed back to traditional wisdom traditions. And this more recent field really emerged in the 70s and 80s out of the environmental movement and preventive care or holistic healthcare movements kind of coming together. All of the work in planetary health is really based on this image, more or less. The first of these was released in 2009. I'm going to walk you through it here. So what you see here are 9 different sections of this pie, and they represent the 9 planetary boundaries that science knows through earth sciences. These are the boundaries that we must not cross if we want to ensure a safe, habitable Earth for humans in particular. And the one you're most familiar with, I imagine, is climate change. You've heard of that one. The other ones are novel entities. In healthcare, that's really going to be thinking about pharmaceutical pollution, for example, all these new chemicals, synthetic chemicals that are being released into the environment. Stratospheric ozone depletion, which you may have heard of as well. Atmospheric aerosol loading. This is things like black carbon, particulate matter, air pollution. Ocean acidification. This has feedback loops with, so as we have more carbon dioxide in the air, that carbon in association with the ocean's water makes the ocean water more acidic. And then you'll see things in the news like coral bleaching and die-offs in those different ecosystems. Biogeochemical flows, you see here both N and P, N for nitrogen, P for phosphorus. These are mainly the synthetic fertilizers that we're putting out into the land for agricultural purposes. Freshwater change, this is the availability of freshwater. And you see here a division between green and blue. Blue represents groundwater and surface water, so lakes and streams. Green water represents the water that is available to plants. So the groundwater that is available for plants to uptake through their roots. Land system change. This is most easily thought of when you think of like the cutting down of the rainforest in order to replace it with agricultural land for growing beef cattle, for example, or changing the natural environment in Southeast Asia in order to produce palm oil. Those sorts of things that are changing the land away from their normal long-term natural ecosystems. And the last one is biosphere integrity. And this is all about genetic diversity and the number of species that are currently on Earth. This one's broken into two different ones as well. One is really thought of, the genetic piece is really thinking about the number of extinctions per million species per year on Earth, knowing that we are now considered to be in the 6th great extinction rate of known history. And then the functional piece of biosphere is more thinking about, for example, when we're thinking of that ocean acidification, coral bleaching, when the coral is bleached, you're going to lose the ecosystem in which other species can thrive. So the functioning of that system has been harmed in some way. So these are the 9 pieces of that pie. And the colors represent green for the safe operating space. We want to stay in the green zone. That means that we haven't surpassed the boundaries. When you start getting into the yellow, orange, you're starting to see increasing risk that we're pushing the boundary. And then when we get more into that high risk zone, we are exceeding those boundaries for certain. So as you can see here, we are in that area of pushing and or exceeding 6 of the 9 boundaries. This is where Planetary Health focuses its efforts in the earth sciences realm. How do we make sure the behaviors, the actions that we're taking as humans are not causing harm to these boundaries in order for us to remain in healthy civilization? So the Lancet, along with the Rockefeller Foundation, had a commission back in 2014 where they really started thinking about planetary health in connection with human health specifically. And they came out with this report. The most important things to share with you are that this was the definition that they came out with. Planetary health is the health of human civilization and the state of the natural systems on which it depends. So that interconnection between those 9 systems, those 9 boundaries for the Earth, and how we are doing, if we are well and healthy, right? When you start to see climate change in clinic, you're going to start seeing more people who have asthma exacerbation with wildfire smoke. You're going to see more heat emergencies, those sorts of things. The other thing I want to point out here is that from this time, the Lancet has created a journal specific to planetary health. And it's really focusing on a number of different realms that come out of the report, mainly that these health effects are resulting from changes to the global environment, and that the solutions really have to focus on enhancing the quality of life for everyone. There's a big component of equity involved in the planetary health field and movement. Health professionals are identified in the original report as one of the key groups of people who has power to act in this realm. And you can see here, it's kind of interesting when you look at health professionals, and the other 5 groups include the UN and governments, and then academics, researchers, corporations, citizens. Health professionals were pulled forth specifically because you see these connections between people coming in, presenting with different ailments that are caused by these larger scale changes that are acting out on a smaller scale, a more localized scale. So you have a clear role to play here. This is just an image to show you that based upon that report and then the early work, they started this journal April 2017, the month of Earth Day was the first time that they published. And since then, every year, they have now published 12 different numbers every year. So there's quite a lot of information. If you're interested in this area, go and just kind of poke around, see what's on that website, see what are in these journals that is of interest to you in making these connections. So why are we here today, right? That's our background information. And now, how do we work together in this space? What does healthcare have to do? So really, it's bi-directional, right? And we've mainly been talking about this role that planetary health has on human health and therefore healthcare, what you're seeing patients come in presenting with. And these can be responding to acute needs, things that we have seen specifically in Vermont injuries during flooding, for example, respiratory illness from wildfire smoke, which we've already discussed, heat illness, which we see in Vermont. The magic number is 87 degrees Fahrenheit. Above 87 degrees, that's when we're going to start seeing a precipitous increase in the number of people coming into emergency rooms for heat illness. Vector-borne diseases, Lyme disease in particular, but more and more emerging diseases, and then mental health needs. The other is those more chronic or long-term health needs. And here I'm just going to kind of put a little placeholder because we're going to come back and thinking about this. Advocating for healthy behaviors has a huge role to play in how healthcare impacts planetary health. So what do I mean by this? One is that the ecological footprint of medical care is quite staggering. You see here some of the numbers of just carbon, right? Greenhouse gas emissions from the healthcare sector. If the US healthcare sector were a country, it would be ranked above the United Kingdom for the amount of carbon that is releasing into the atmosphere on an annual basis. We have a very large carbon footprint in our system. Novel entities, pharmaceutical. So this is the one that I am most familiar with and do the most work in. And we'll talk about it more as we go, but anything we can do to decrease our reliance on pharmaceuticals in favor of evidence-based options for people, other therapies that are just as effective, is going to be a benefit to the environment because we won't be releasing these chemicals into the environment. And again, we'll be talking about that more in a minute. We also have a big opportunity here, right? That idea that the Lancet Commission is saying healthcare providers are one of the 6 key groups of people who play a role here. We have an opportunity to educate, to advocate, to do research, to really identify these connections between how health and healthy behaviors can actually help us improve health outcomes for the planet. Because the actions that we need to take for humans to truly be healthy, right? Thinking of the numbers of people who are experiencing homelessness in Vermont. Yesterday on Vermont Edition, they were talking about homelessness, and the numbers are, it's up to close to, oh, now I'm trying to remember this specific number, so I'm not going to put it out there because it's just left my head. But we have a high number of people experiencing homelessness. We also have a high number of people experiencing food security. That number, I recall, is close to 10%. Close to 10% of Vermonters are experiencing food insecurity. How can you be healthy if you're experiencing food insecurity, right? So the things that we need to do to be healthy, truly healthy, mind, body, spirit, social connections, those are the same actions that we need to take that will heal the damage we've done to the planet. This statement is coming from a conversation that I had with Bruce Barrett, who is a clinician, MD, PhD out at Madison, Wisconsin, who said something perhaps more eloquent than the way that I posted it here. But this has been a driving force for me over the past couple of months since talking to him about it. This idea that I want to just plant with you. What does it mean to be truly healthy? How can we help those people who are coming in for care to really be healthy in this whole person way? So taking just a step forward into trying to understand these connections, here's just one brief example of how all these things play out from the point of care. So here we see a pretty ubiquitous item that you'll see in healthcare centers across the country, around the world, right? The humble IV bag containing some sort of pharmaceutical chemical to support health. It's on a metal pole, it's in a plastic bag, it has an IV tube. All of those materials came from somewhere. And we don't think about that. And maybe we shouldn't have to think about that at the point of care when you're working with a patient. But we need to at least remember it, that all of those items came from somewhere. They were harvested from a natural environment. They were transported, they were manufactured, they were packaged, they were transported again. then we use them for a very brief amount of time, and then we toss them. And they go into municipal landfill, they go into incineration, depending on the pathway that is most appropriate for their disposal. And all of those different upstream and downstream places will have some sort of environmental degradation that is related to the health of the people in those places. You just want to, put that out there, something to just think about. In one of the studies that I did looking at nitrile gloves, the average amount of time people in an oncology inpatient unit were using nitrile gloves was 3 seconds per pair of glove because of the social factors, institutional practices, requirements for infection control, making sure that people walk into the room with their gloves on before assessing whether or not they needed the gloves, before knowing whether or not they had to touch something that was going to be infectious, drippable, pourable, squeezable, right? And so since many of the times the people I was following didn't need their gloves on, they would walk into the room with the gloves because that was the standard practice. They would realize they didn't need them, off go the gloves into the trash, never even used. Just thinking about that, right? As my role in that setting as an ethnographer, participant, observer, just watching, just identifying where are these touch points for understanding the factors that drive these different impacts. How can we work within a system to make sure that the practices that we are using are appropriate to actually serve the purpose of protecting the provider and the patient from any sort of pathogen, for example, while also respecting the fact that those gloves do have a bigger impact, especially knowing how many billions of gloves are being used every year in this country, especially since the pandemic, right? More and more infection control happening, even in the general public, right? Like during the pandemic, we were seeing people in the grocery stores wearing gloves as well, that sort of idea. Okay, so what are some of those factors that are governing these impacts? I've already talked a little bit about one, right? That idea of how the culture of a place will determine how long someone is wearing gloves and how much waste is generated. Others are the idea of policies, right? Institutional policies, federal policies. One of the things that I've seen in my travels is the idea that concerns over drug diversion or opiates, controlled substances, is higher than the concern for planetary health. So what I mean by this is in another setting where I was, this was in a hospice unit. Again, a participant observation was what I was doing. And talking to nurses in particular who provided care in the home for patients who were dying. And after a patient passed, the nurses would perform a service for the family. They would collect all of the unused medication, which, as you know, can be a pretty large volume of medication. If someone has been through chronic care for several years. So they would collect all those medications, and their practice, because of the Drug Enforcement Agency, US agency policies, was to dump everything into the toilet, flush it down the drain. Or for fentanyl patches, they would cut them up and put them in the trash. So all of those different substances going directly into surface waters. You'll see that come up again in a minute when I'm talking more about pharmaceuticals specifically. But there are other alternatives available. It's just how do we work together with researchers and clinicians and administrators and policymakers to make sure that there are better options available to those nurses? How could we allow people to have a lockbox in their car to transport materials, something like that, right? What are the different approaches that we could take that would overcome these current policies? How do we redevelop those policies? Another is just the idea that the medical decision making that happens is what's driving all of these different volumes of pharmaceuticals being used, the volumes of gloves that are being used, IV poles that are needed. And I'll break this down a little bit. So this is coming from the research that I did, again, as a participant observer. So I'm shadowing, I'm following doctors and nurses and social workers through 3 end-of-life care facilities for people who are dying of cancer. And one was a conventional cancer unit, one was a palliative care unit within the same hospital, and one was a standalone hospice facility. And what I found was in the conventional unit, this place had the most impact in terms of cumulative number of just materials being used per person, per patient day, compared to palliative care and hospice. And it makes sense, right? Like the curative model is to do everything we can, put everything in there to make sure that we are helping a patient towards cure. The patients in the conventional unit, 70%, there had been a study done on the unit, maybe like 3 years previous, which had identified the need for palliative care and created the palliative care unit. 70% of the patients in the conventional unit would die within 6 months. They were eligible for hospice. The majority did not get hospice until the final 18 days of care. So what we're seeing here is the idea of making sure that our providers were trained and comfortable and confident to have conversations, these really difficult end-of-life conversations with patients who are nearing death, about goals, about what would you like the quality of your life to look like for the final 6 months, right? And I know that this is really hard because, prognosis is really hard. How do you really know when someone was in that 6 months? And at the same time, we know that having those conversations early, making sure that palliative care is an option and a component of care from the very beginning of an oncology diagnosis is a best practice, right? When you have palliative care working together with conventional oncology in particular, you're going to have better outcomes for the patient. Whether or not you ever need hospice care, knowing that those conversations of quality of life are happening throughout. And then when the time is right, when it's medically appropriate to transition someone, the sooner you can get somebody into hospice care, the better the results are for the patient. Less pain, less spiritual pain, the better the results are for the community, the family members who are caring for that person, because they have those social supports, social work and such that become available to them through hospice. And we have better outcomes for the planet, because when we transition away from that curative mode when appropriate, we reduce the amount of materials that are going into that care in terms of those chemotherapy drugs in particular that have a really high impact on the environment because of the way that our bodies will excrete active ingredient, for example, and it goes out into the wastewater, which again, we'll talk about. So that medical decision-making and how we're talking to our patients and the relationship that we have with our patients is really important. And it drives all of these other impacts. The other area that kind of grew out of this, so the study was what resulted in my work in Dying Green, really started focusing on pharmaceuticals and this idea that we really do in this country rely on pharmaceuticals to treat a lot of illnesses, that there are other options available to us. And it's a complex web of reasons why, right? We're seeing still advertisements in television, ask your doctor. And so your patients are coming in and asking you for these things. You only have 15 minutes often to talk to someone in different settings. If you only have 15 minutes and somebody's asking for something and you want to make sure that your quality of care is high and that the satisfaction is high when the person returns that survey, like you might be more likely, right? We know this. You're going to be more likely to prescribe something rather than having time to sit down and ask the person about their nutritional needs. How are they sleeping? How's their stress management? What is their physical activity? What are the things that we could be doing to support that health in this different way that would negate the need for pharmaceuticals? for example. So here is a very busy image, and I'll walk you through it. This is from a study that I did with colleagues at the U.S. Geological Survey. We went for 10 days back in May of 2014, and we put these auto samplers down in the wastewater treatment plant. So it's just this kind of big cylinder that takes samples of water at a certain amount of time over the course of 24 hours for 10 days. And we put it at the place where the wastewater comes into the wastewater plant and at the place where it goes out. So that incoming water is called influent. And those are the red dots that we see all over the screen. And the water that goes out is the effluent, the blue dots that we see. Okay, so that's kind of the basics. What you're also seeing here is these different groupings are different classes of drugs. So we see antidepressants, for example, antiviral, opioids, ulcer and diabetic medication. So different classes. Each of the individual lines is a specific pharmaceutical. And so now putting all those pieces together, for each of these pharmaceuticals, we'll see red dots, how much, what is the actual concentration of pharmaceutical in the wastewater coming into the plant, and then blue, what is the concentration leaving the plant. What those two things together give us is this yellow dot over here, or green dot, and these dots tell us the percent change. What we want to see is that through the wastewater treatment plant, it's removing those pharmaceuticals before it exits directly into Lake Champlain. Those are the green dots, is what we were really looking for. This means that 80% or higher percent of those drugs were removed effectively. And what we find is that of the 54 pharmaceuticals that we detected, out of the 110 that we were able to test for at the National Water Quality Lab, only 8 of those chemicals were being removed at 80% efficiency. So that means that we have quite a large number of pharmaceuticals directly entering Lake Champlain. Now, a couple of things here. One, this is not unique to Burlington or to our wastewater treatment plant. These are the same types of numbers that we're seeing across the country and around the world. And it relates to the fact that wastewater treatment plants are not designed to remove pharmaceuticals. They're designed to remove solids, and they do a really good job of that. In order to remove pharmaceuticals, there's been a lot of work done on all sorts of technologies to try to figure out how do we do this. Brian Brooks at Baylor University down in Texas is the preeminent scholar in this area. And I've had conversations with him where he says that even reverse osmosis won't remove all of these pharmaceuticals. There isn't a technology currently that can remove all the pharmaceuticals. If you do find a technology that you could implement that will remove some pharmaceuticals, it's millions of dollars per wastewater treatment plant. And there are wastewater treatment plants, how many do we even have in the state of Vermont? We have a few hundred wastewater treatment plants in the state of Vermont. So it would be an exorbitant cost that suggests, let's look upstream. How do we prevent these pharmaceuticals from entering? So what are the sources of pharmaceutical? Right. There's a small amount of pharmaceutical that is entering the wastewater, coming down the drain by people who are disposing of, right? But it's a very small percentage, right? I gave the example of hospice nurses providing that service to patients disposing of. That's a pretty rare thing when you look across the population. When we've done surveys in the state of Vermont and surveys around the nation, we see it's less than 20% have ever disposed of things. It's closer to 12% of people will say that they've disposed of something down the drain in the past year. So it's not disposal. It's coming through excretion, right? Because depending on the chemical, our bodies don't fully metabolize, or we excrete either the active ingredient or some form of active ingredient. So these chemicals are entering our wastewater because we're consuming them, which again just leads me to ask, what are the things that we could do that would decrease our reliance on pharmaceuticals that have the same benefit to the patient? So that's where I am. These are the things that are of most interest to me. So here's a little bit of evidence, right? I was saying that this is not unique to Burlington. 139 different streams sampled by the US Geological Survey, the same general group of people who I worked with here in Burlington. 80% of the streams have detectable levels of pharmaceutical. When USGS has gone and looked at municipal drinking water, so tap water directly, in 25 large municipal drinking water plants, 100% of samples have some amount of pharmaceutical. We're just not able to clean these out, whether through the wastewater or through the intake into the drinking water. All of these pharmaceuticals are designed to have a biological response within the body. What does that mean out in the environment? We don't really know. There's been a lot of work done in this area, starting in 1999 with a researcher, PhD, Christian Dodden at the EPA, Environmental Protection Agency, really started spearheading this area and just asking, are these pharmaceuticals in the environment agents of subtle change? Because they're not constant, but they're pseudo persistent, right? Each individual, like on a day, a chemical goes out into Lake Champlain, for example, that particular chemical on that particular day, it will degrade naturally within some amount of time, usually pretty short, maybe 7 days, maybe 10 days, depending on the chemical. But since we're reintroducing with every flush of the toilet, they're pseudo persistent. That chemical is always there because it's always being re-entered into the system. What does that mean? So there have been studies looking from the very smallest species in places like Lake Champlain. This is the very base of the food chain, these little zooplankton. And we're seeing that they have different changes in behavior, different physiological changes because of pharmaceutical. Some great studies with wonderful names like fish on Prozac and Zoloft 10 years later. So we've been studying this for a long time. We know that antidepressants and anxiety medications do have a behavioral effect on fish. It makes them more aggressive. They're less likely to be hiding and concerned. They're less anxious about other people coming out to, eat them. So that changes the dynamics of the populations. And we still don't really know what does it mean that we have these pharmaceuticals in our drinking water. I mean, this is a long-term question. When the idea that USGS likes to say is, like, let's not be really reactionary about this. There's pharmaceutical in drinking water. We're testing this, but the concentrations are so small. You would need to drink a swimming pool, an Olympic-sized swimming pool volume worth of water to get any one dose of these drugs. And the question is, again, when it's this pseudo persistence and it's a mixture, a cocktail of drugs, what does that mean? Like, we don't know. It's going to be a long-term study to try to figure out what are the potential true impacts on health. So based on the evidence that I've been collecting over many years now, 14 years, we need evidence-based approaches that will help us in healthcare to support human health that don't have these planetary health impacts. And coming back to this earlier image, just highlighting again this idea that I collected from Bruce Barrett, that those actions that we need to take that will truly help us be healthy are those actions that we need to take that will help heal the damage we've done to our planet. I'll just leave that there. I'm happy. These are philosophical questions. Happy to discuss anytime with anyone who's interested. When we're talking here, we're really thinking about how do we promote whole person health. How many of you are familiar with the term whole person health? Okay, so some, not all. Fantastic. I mean, the right group of people. Whole person health. What is this? Okay, so here's the idea. And we'll get more into whole person health specifically. But in order for healthcare to identify these different strategies that we have, one, really, when we're using whole person health, we can keep people healthy, keep them out of the healthcare system for as long as possible, so that they don't pharmaceuticals, for example, so that they don't need to be in a healthcare setting where we have to wear the gloves, all those different things. Keep people healthy. And the second is when someone is ill, to integrate all the available therapeutic tools that have an evidence base that help us make sure that we're promoting healing in a way that will benefit the patient and the planet, that we're not just hitting symptoms and organs with pharmaceuticals, for example. Again, that's just my area of interest, but that we are looking at alternatives that take into account the whole person, their mind, their body, their spirit. We know through UVM's comprehensive pain program, a lot of pain is really derived from spiritual pain. How do we make sure that people have access to spiritual care? How do we get those conversations into healthcare in an appropriate way, right? You don't all need to be spiritual advisors, but you need to recognize that spiritual pain can be one of those places where pain is really coming from, and that it might be a much different pathway that will help someone to overcome that pain than throwing a pharmaceutical at it, for example. Okay, so integrative health. This is the area where we're thinking about whole person health. And this is coming from Helene Langevin. Does anyone in this room know Helene? Okay, so Helene was on the faculty here, and now she's the director of National Institutes of Health, National Center for Complementary and Integrative Health. And this is a quote from her that both brings together this idea of whole person health and the idea that connection to natural world, here we're using the term planetary health, is an important direction for us to be taking. So integrative health is the area where we are seeing these connections most clearly right now. Integrative health, it brings evidence-based therapies together from both conventional care and these complementary, sometimes called alternative healthcare options, brings them together in a coordinated way to make sure that we are supporting the whole person. And it emphasizes this multimodal, that there might be many different therapies necessary to help treat the whole person, mind, body, spirit, social connection. Here, we're going to transition into taking all that information and thinking about, okay, what does this mean for clinical care? So what are some of these opportunities? How many of you have seen the 3-4-50 campaign previously? Okay, couple people. So 3-4-50, this came from the American Public Health Association and has been really adopted and grabbed onto by our Vermont Department of Health in particular. It's the 3 behaviors that cause the 4 diseases that lead to 50% of deaths in the United States of America. And those 3 behaviors: no physical activity, poor nutrition, and tobacco use. So in Vermont, 47% of adults don't get recommended physical activity. 20% report no physical activity. How could we talk to change the conversation when we're talking to patients? Again, depending on specialty, right? How do you apply this from your specialty? How do we talk to people about their physical activity? Because we know physical activity is hugely important in disease progression. 61% of adults not getting the fruits that are recommended, 70% not getting vegetables. How do we make sure we're having those conversations about nutrition? 16% of adults smoking. what are the things that we need to be working on? And we have a huge arm of research here at UVM that works specifically on tobacco use. So how do we all come together to make sure that we are providing care that is thinking about these behavioral changes, that if we made these behavioral changes, we would be reducing the rates of disease. We wouldn't need to be providing care in clinic. We would be improving health outcomes for people, right? 50% of deaths. How do we improve those numbers and thereby improve planetary health outcomes of the healthcare sector? So integrative health is a place that offers a lot of opportunities, right? That combination of conventional care and evidence-based non-conventional approaches through disease prevention and disease treatment. So here's a list of these different types of things. So categories. We have lifestyle tools. This is like that 3-4-50 campaign, right? How do we make sure that we're talking to patients about nutrition, physical activity, tobacco use? You would add in stress management. You could add in connections with nature. That's a spiritual component for many people. Then you have these other categories: mind-body therapy, biochemical therapy, biomechanical, and bioenergetic. The thing that's missing here, actually, note to self, I should add, are whole systems like Ayurveda and traditional Chinese medicine. So let me just gauge here. When you hear some of these things and you see this list, how many of you have an initial reaction of, that is not evidence-based? Thank you for your honesty, because I think many of us, me too. I started off in this role working in integrative health as being very skeptical. And particularly through an undergraduate course that I teach on the science and evidence of integrative health, I've become very aware of the evidence that is available to us that shows that these tools work. So I'm going to just run through a little bit of information. So last night, I was trying to think, oh gosh, I haven't actually integrated this piece in. How do I do this? I set a little timer for 20 minutes, and I just searched through PubMed for randomized controlled trials, and then those 4 diseases: cancer, heart disease, lung disease, diabetes, and integrative health therapy. Sometimes I would put in a specific therapy. I just kind of playing around. What could I find? I'm just going to run through this. So these are all since 2020. I think is the earliest. I think 2019 was the earliest one that I set my limits for. So here we have evidence, systematic review of acupuncture, acupressure in cancer, efficacy studies for a variety of integrative health in cancer, systematic review for anxiety, cancer, anxiety being something that we would tend to first line give a pharmaceutical for, in particular, non-pharmacological interventions for breathlessness in cancer, right? For diabetes care, thinking about folic acid, vitamin B12 in conjunction with standard care improves outcomes. Nutrition, increasing psyllium fiber to help control diabetes as well. So this was just 20 minutes of searching. And the most time that I spent was actually taking these screen clippings and making them look nice and put them in. There is a lot of data out there if you search for it. If you search for randomized controlled trial, which I know is the gold standard, right? Search for the specifics of whatever the topic of interest is for you, and search for, integrative health widely or for specific things that you feel more comfortable with to start with. Maybe, like, how many of you have heard of yoga and feel like that's something that might be kind of safe for people, right? I'm being a little facetious. I'm imagining that more hands would go up than that. But search for things that you're comfortable with to start with. And from there, see what the evidence says, see where it leads you, and identifying other options that are available. Because I understand very clearly, because I was there is skepticism around many of these therapies. And there doesn't have to be any more if you know where to look. Okay, so patient and provider education. Here's another place where we have an opportunity to move forward, right? We have the clinical care specifically. Now, how do we increase awareness around these things? So for integrative health, something that you should know, more than 30% of adults in the US report using these therapies, many without telling their doctor, right? And you know that. People are taking herbal supplements on their own. What if you have a role to play in that, in doing the searches, telling us in the research departments, what searches do you need us to do for you to pull together a list of information that you can have at your disposal that could pop up in Epic, for example, that would provide you the information you need when someone says, oh, yeah, actually, you're right. Thanks for asking. I do use herbal supplements. I'm using XYZ. And it can pop up and be like, nope, this one is not evidence-based for this particular illness. Oh, yes, this one is. Think about that instead, right? How do we integrate these different therapies? This is a resource I want to just let you know. It's in Dana Medical Library, both as a hard copy and electronically. This is the go-to Bible. I'm pretty sure that the 5th edition came out in November of 2022, and it is just full of information to get you started. It's broken down by both. There's one section that breaks down the specific modality, the specific therapy. Like there's a whole section on acupuncture, for example, or functional food. And then there's a whole other section divided specifically by disease type. So a whole area on cancer, a whole area on heart disease. Come and look. It has all of the best, most current evidence as of November 2022 pulled together to get you started in thinking about how do we rethink what we're providing to people. How do we then educate people, both providers and our patients, about planetary health? So a couple of things I want you to know. Climate change is the #1 concern, and we're seeing that. And a couple of years ago, 200 leading medical journals around the world issued a joint statement during the height of the pandemic that climate change is the #1 most pressing health concern of our time. So we know this. There are tons of resources available for trainings and such, but we need to make sure that it's accessible to our providers, because you are a trusted source of information about climate change, among the very most trusted sources of information. And we know from surveys that providers aren't confident. They haven't gotten training in this area. Only 55% of medical schools offer anything at all in climate. But you're seeing people presenting with respiratory illness and these different heat illnesses. How do you talk to patients about that? And I'll note, next week on Thursday in the Teaching Academy Snow Season Retreat, we're going to have a plenary speaker and then a workshop specifically on planetary health, and we're going to be focusing on climate change. So please join us for that as well. Okay, policy change. I'm going to run through these kind of quickly because we're getting short on time. But thinking about standards for integrating this material into medical training. How do we make sure that patients have insurance coverage for integrative health care, right? This is a big topic in terms of paying for care. There's a policy there. We need, for pharmaceutical disposal, we need clear coordinated messaging from DEA, EPA that right now are at odds. DEA says dump it down the drain. EPA is saying bring it to take back. Take back is the preferred method for disposal. We need to decarbonize the healthcare sector. And that includes all of these different things together. And there's other things that we could think about as well. So conclusions, healthcare has a tremendous impact on planetary health. and because of that connection, human health as well. Clinical care is the next area for greening. We have a tremendous resource here at UVM Medical Center and now at UVM Health Network, expanding out their sustainability council, sustainability work. At UVM, we have an office of sustainability. We need to move beyond and above and with the support of those places that are focusing on, changing the light bulbs and making sure that the energy that we're using is green energy. We need to implement clinical care decision-making into those conversations. You have a role to play in this. And integrative health, I really truly believe, after moving through my skepticism through the research, is a promising area for us to be working. So I'm going to leave you with a couple questions here. What role can you play in this transition? How do you help align these different pieces of healthcare and planetary health? How can you educate patients? What do you need to make sure that you are comfortable and confident in the knowledge that you have to share? And what policy changes do you need? And please feel free to reach out to me, reach out to Dr. Latreille to get connected to the growing group of people here and around the country who are working in these areas from all these different clinical science, research, teaching. We have a huge role to play. And I love to say this piece, there's no room for ego here. It's a very friendly playing ground because we need to do this work and we need it now. So anything we can do to share and support each other's work is going to benefit us all. And I'll just leave you with a quote from Sir David Attenborough about the connections between these different pieces. And I think we have 1 minute. I did not leave much time. So thank you all. If anyone has a wrap up for us. And yeah, please come and join us. Thank you all.
There's one question on the team.
Wonderful. Yes, I'm happy to stay if anybody has a question and has time.
As much as I try to encourage patients to stop supplements with no known health benefits, they prefer their supplements and will rarely stop using them. How can structural change, like FDA regulation of advertising, change this? Can that even happen?
That's a fantastic question. Yes, and I'm sure that's a frustration of clinicians, right? When patients are using things that are, outside of the evidence base. I think regulation is a key component of that. Absolutely. And I think that that's part of the policy conversation. How do we make sure that we are working with those federal agencies to restrict things when there's no known evidence? Thanks for the question. Yeah, we have a question in the audience.
Your work on the pharmaceuticals in the lake are really very, very interesting. Has there been any work done on looking at these supplements and non-evidence-based stuff in the lake as well? I think
that's a really great question. No, not to my knowledge, but it's a very interesting question because similarly, it's curious. I think a lot of people will think, oh, well, they're natural substances, so they're going to break down. But it's the same idea. Even if they do break down, they're being constantly reintroduced if they are being excreted in an active substance. So that's a really great idea. I haven't looked into the area. People may be looking at it. I'm going to go back and do a little research to see what the literature says yet. Thanks for the idea. Any other questions or?
I think we're at the 9 o'clock hour. So if anyone has any questions, thank you for offering to stick around. Otherwise, thank you so much for coming. See you guys next.
Thank you all.